I like to discuss for this board review in constriction to recognize clinical symptoms and signs, and also I like to summarize imaging criteria and also the hemodynamic criteria for diagnosis, and then describe a spectrum of constrictive pericarditis and recognize distinction between the restriction and constriction. And then we'll review with you a treatment of a constriction and provide you with the important prognostic parameters in this disease. So in constrictive pericarditis is predominantly right heart failure, and you'll see in patients with a constriction most likely ascites in the edema, and also jugular venous pressure, as you see in this patient, is most of the patients do have elevation of jugular venous pressure with a Kussmaul sign, and then early diastole, the Y descent is quite rapid because of the high right atrial pressure at the opening of the tricuspid valve, and then makes the third heart sounds called pericardial knock. And also the subset of patients will present with the pleural effusion. So if you look at this slide showing the constriction and restrictive cardiomyopathy, again, I want to emphasize that they may present similar way clinically, but the underlying mechanism is quite different because both will present with heart failure because of the limited diastolic filling. But in constriction, the limited diastolic filling happens because of the thickened or fibrosed, scarred, or calcified pericardium limiting the filling, and then that creates the interventricular dependence with this very characteristic septal motion on echocardiography and also cardiac MRI. But in patients with a restrictive cardiomyopathy, whether thick walls, hypertrophy, or fibrosis, the diastolic filling is limited because of the muscle problem, not the pericardium. And then you see the more slow relaxation of the heart, not like the patients with the constrictive pericarditis in echocardiography and cardiac MRI. So traditional imaging and hemodynamic features are listed here. Pericardial thickness is increased, and then subset of patients has a pericardial calcification. You can tell on chest X-ray or CT. And also there are gold standard hemodynamic criteria by cardiac catheterization, as I listed here, and I'll go over that individually. Although we emphasize the increased pericardial thickness, I just want to remind you that the normal pericardial thickness cannot exclude the constrictive pericarditis. Because when we looked at our 143 patients with constriction surgically proven, and when we look at their surgical specimen on the microscope, the 18% of them did have pericardial thickness of 2 millimeter or less, normal pericardial thickness, and the 82% had the thickened pericardium. So subset of them can present with the relatively normal pericardial thickness, especially in patients with a mixed, meaning superimposed myocardial disease, and such as in radiation therapy or previous cardiac surgery or myocardial infarction, they can present with a constriction and relatively normal pericardial thickness. And this is interesting data we just published a year ago, and showing the relationship between the right atrial pressure over pulmonary arterial wedge pressure ratio, and then pericardial thickness is over here. And the patients with a relatively normal pericardial thickness here, those are the patients with a mixed constrictive pericarditis. They actually have a lower right atrial pressure over the pulmonary arterial wedge pressure ratio here, meaning the right atrial pressure indicates the intrapericardial pressure, and that pressure is somewhat lower in patients with a mixed constrictive pericarditis rather than primary or pure constrictive pericarditis. I'll get back to this particular parameter when we discuss the prognostic feature in patients with a constriction. And also, what about calcification? They used to be all related to tuberculosis. It is quite uncommon in this country. But in developing countries, still tuberculosis is one of the more common cause of constrictive pericarditis. It's already 20 years ago when you look at this, look at our population with constriction, but 27% of them had the calcification on chest X-ray. But whether they had the calcification or not, their outcomes are quite similar after pericardectomy. And also, I'd like to emphasize that even having pericardial calcification may not be diagnostic for constrictive pericarditis. So we got to make sure that we come up with a hemodynamic criteria for constriction to make that diagnosis of constrictive pericarditis. And all of us consider the invasive hemodynamic pressure tracing as a gold standard for diagnosis of constriction. And the first report of right heart cath pressure tracing in constriction was published in 1946 from NYU. And these investigators are very prominent in that they received Nobel Prize for their work in cardiac catheterization. And when they present this patient out of a 77 case illustration, that's number 64, with a constriction, they've reported the correctly increased right atrial pressure, and then normal RV systolic pressures, and increased RV diastolic pressure because of the limited diastolic filling, and also very rapid rise of the early diastolic filling with a plateau, and creating the square root deep and plateau sign as you see in this pressure tracing. That was 1946. But soon after that, for many papers came out. As you see, I'll show you later that similar things been presented in patients with the restrictive cardiomyopathy. And also, when you see this square root sign, you see the very early diastolic dip, rapid rise of the filling during diastole, early diastole, and then plateau. And then you can see that in the M-mode echocardiogram, because this is a very rapid early diastolic filling and then plateaus. And this is when we hear a third heart sound called pericardial knock, because of the very rapid flow coming from the atrium to the ventricle and hitting the wall of the ventricle and then plateau. And that's when we hear the third heart sound we call pericardial knock in patients with the constriction. But we also hear that not the same sounds, but the third heart sounds in patients with the restrictive cardiomyopathy because of the similar type of rapid filling of the ventricle. And then again, this is one of those articles I just mentioned, that similar pressure tracing, deep and plateau, and then this is the atrial pressure tracing, not from constriction in this case, although similar, but in patients with the cardiac amyloidosis. So they realized in 1950s and 1960s that the restriction and constrictive pericarditis can present with a similar hemodynamic pressure tracing, and they tried to figure out what features can distinguish one from the other. So this is the one attempt that when we compare the constriction and restriction and the simultaneous LV and RV pressure tracing, in restriction, more of patients with the restriction had the higher LV diastolic pressure than RV diastolic pressure. So the difference of more than 5 millimeter mercury between LV and RV EDP became one of the diagnostic criteria of restriction, distinguished that from constrictive pericarditis. However, when our group look at the many patients with the constriction and restrictive cardiomyopathy patients, that equalization of LV and RV EDP, and also PA systolic pressure of 50 millimeter mercury or less for constriction. That's one of the hemodynamic diagnostic criteria. And then RV-EDP over PA systolic pressure greater than 1/3. All of them had about 80% overlap with the restrictive cardiomyopathy. So this is really challenging for us to use the traditional hemodynamic diagnostic criteria for constriction and differentiate that from restrictive myocardial disease. So if you look at this square root sign or rapid rise of the diastolic pressures, and this happens in patients with the restriction and patients with the constriction, and that can be also detected by Doppler echocardiography. This is a pulse wave mitral inflow velocity showing the early diastolic filling, which is rapid filling, and then the lower filling with atrial contraction because of the increased diastolic velocity at the mid to late systole. Atrial contribution is relatively less. And because of the rapid rise of the early diastolic filling, we have a very short deceleration time, meaning from the time of the peak velocity to the time it reaches a baseline, we call that as a deceleration time. And usually that's longer than 200 milliseconds. But in patients with the high filling pressure and very rapid rise of the early diastolic pressure, we have a shorter decel time, as you see in this diagram. I think that the really characteristic hemodynamics of constriction was really provided by Dr. Liv Hadley when she was a visiting professor at Stanford and working with Dr. Christopher Appleton. And as you see here on your right side, in patients with restrictive cardiomyopathy, when you see the intrathoracic pressure, the pulmonary capillary wedge pressure, and then left ventricular pressure during diastole, when we breathe in during inspiration, the intrathoracic pressure, meaning pulmonary capillary wedge pressure, falls here with the inspiration, and that pressure change, the drop in blood, the intrathoracic pressure, transmitted equally fully to the left ventricle or intracardiac cavity, so the LV diastolic pressure also falls, so that the pressure gradients, driving pressure gradient to the left side chamber, does not change whether inspiration or expiration. But in patients with the constriction, there's a dissociation between the intracardiac and intrathoracic pressure. Let me just show you that a little more clearly on next slide. And when Dr. Liv Hadley finished her professorship at Stanford, and lucky for us, she came to Mayo Clinic to spend another year with us. And we were very interested in this non-invasive hemodynamics and also constriction and restriction. And Dr. Nishimura, very interested in hemodynamics, and he's doing the cardiac catheterizations. And I'm doing simultaneously doing Doppler echocardiography, mitral inflow velocity in a patient with a constrictive pericarditis. So with inspiration, again, intrathoracic pressure falls. So pulmonary capillary or pulmonary arterial wedge pressure falls, few millimeter mercury, but LV diastolic pressure does not fall too much less than intrathoracic pressure. So as a result, you have a marked decrease driving pressure gradient to the left side chamber, so that if you do mitral inflow velocity, E velocity decreases from expiration, and when you have an expiration, then the pulmonary wedge pressure goes up again, and then without significant change in the left ventricular pressure change, you have an increase driving pressure gradient to the left side chambers. So let me just show you one more time, because this is a crucial point of the hemodynamic mechanism of constriction. And we want to add one more characteristic, that is interventricular dependence, which is unique to constriction because of the thickened pericardial layer, as illustrated with the yellow line here, the combined cardiac volumes, left and right sides, are constant. So if you increase filling to the left side chamber, that will decrease filling to the right, and vice versa. So let me just show you this animation then with the pressure tracing on the top, with the intrapulmonary, intrathoracic pressure in purple, and intracardiac pressure, LV pressure, as a blue. So with the inspiration, you can see the intrathoracic pressure falls, but the LV diastolic pressure stays similar, not without significant change. That decrease filling to the left side chamber, allowing septum to deviate to the left, more filling to the right side chamber. So pulmonary vein, the diastolic velocity and mitral inflow velocity will decrease with the inspiration, and tricuspid inflow velocity will increase, and hepatic vein Doppler forward flow velocity will increase, but reverse is much less. With expiration, you have the increased intrathoracic pressure with a minimal change in the cardiac pressure, increased pressure here, flow, and the septal deviate to the right, and more filling. You see the pulmonary vein and mitral inflow velocity with expiration, and you can see that reduction in tricuspid valve flow, and then significant flow reversal with expiration, as I show you in this animation. So we need to demonstrate these two features, whether you do by echocardiography or by cardiac catheterization, to diagnose constriction correctly and separate it or distinguish it from restrictive myocardial disease. So another important diagnostic parameter for echocardiography came from this observation. The E prime velocity, that is the early diastolic velocity of the mitral annulus, that is the parameter that corresponds or reflects the LV relaxation very well. So normally, in normal individuals with the normal myocardial relaxation, E prime velocity is about 8 to 10, or sometimes young individuals up to 15 centimeters per second. But in all individuals or all patients with the myocardial disease, the relaxation is the first property, one of the first properties to become abnormal. So E prime velocity then by Doppler echocardiography, by tissue Doppler echocardiography from the medial annulus in this case, that decreases to 3, 4, 5, 6 centimeters compared to the normal E prime velocity of 8 to 12 centimeters per second. But in patients with the constriction, because of the lateral confinement here, you cannot have much of a lateral move. The only way this heart with a constriction, the way to increase cardiac filling is increase movement of the mitral annulus, so that E prime velocity is actually increased in patients with a constriction. There are significant, it's a paradoxical, very opposite between the restriction, myocardial disease, and constrictive pericarditis. So this is the data that we put together, although this initial observation was made by Dr. Mario Garcia when he was at Cleveland Clinic, and he's now at the Einstein in New York. We look at this parameter in constriction, cardiac amyloid, and restrictive cardiomyopathy. As you can see, there's really little, very little overlap between the myocardial disease and pericardial constriction when we use E prime velocity of 8 or 9 centimeters per second, as you can see. So this has become very important parameter to distinguish between two conditions and also diagnose constrictive pericarditis. So with our extensive experience, almost more than 20 years of experience of using Doppler echocardiography, we established and published this echocardiographic diagnostic criteria for constriction. They are septal motion abnormality. I already showed you why that happens. It's because of the interventricular dependence, more filling to the left with the expiration, then less filling to the right, and vice versa with inspiration. And you're gonna see this the septal motion change to the left with the inspiration, to the right with the expiration, as you see. And the mitral inflow velocity is very restrictive, although most of them has a respiratory variation of 25% or greater from inspiration to the expiration, but 20 to 30% of them may not have any respiratory variations at all. And E prime velocity of 8 centimeter per second or greater, and the most specifically hepatic vein Doppler diastolic flow reversal, as you see here, with expiration, not inspiration. So if you, if in someone with the jugular venous distension, the right heart failure, and echocardiography show these features, and we can be quite sure that patients do have the constrictive pericarditis. And I'm just showing you importance of hepatic vein. I'm not sure whether you're gonna be asked this type of thing in the heart failure board, but the echocardiography board, they'll be asking you. But the clinical practice-wise is very important because this is normal hepatic vein with a minimal diastolic flow reversal in constriction and expiration. But in myocardial disease, you also have diastolic flow reversal, but with inspiration, opposite, paradoxical, right? This happens because the venous return will increase, as you know, with inspiration, and with the diseased myocardium, that increased venous return of blood flow cannot be all accommodated, so it has to go back to the hepatic vein. And then sometimes severe TR can be confused clinically, but they have the flow reversal back into the hepatic vein during systole, not diastole. So this is a very good things to do clinically when you do echocardiogram to separate different types of right heart failures. And this is an example of myocardial disease. And again, similar the mitral inflow velocity, very restrictive. The LV function is preserved, but the strain imaging is very characteristic for cardiac amyloid. We call this as apical sparing. The red is normal, but all this basal portion and the mid portion of the heart is quite reduced in the myocardial thickening. And also the mitral annulus velocity is markedly decreased to 4 centimeters per second. So constriction really cannot have E prime over 4 centimeters per second. It has to be, most of times, it has to be more than 8 centimeters per second or so. So this is a typical restrictive cardiomyopathy. And as Dr. Liv Hadley initially showed this interventricular dependence, and she got the idea actually from cardiac catheterization that nobody else recognized. And we did further studies to confirm that if in restriction and constriction. If you look at the both pressure tracing, one from restriction and one from constriction, both the equalization of diastolic pressures, really superficially, they look quite similar. You really cannot tell one from the other, right? But in restriction, when you have the simultaneous left ventricular pressure and the right ventricular pressure, those pressure changes concordantly. They drop or decreases with inspiration and increases with expiration. But in patients with the constriction, it's interesting that LV pressure falls with inspiration, but the RV pressure increases. And also the width of the pressure is increases with the inspiration here in RV, and then decreases with the expiration, as you see. and then those changes are quite opposite in the left ventricular pressure tracing. So that's the more specific changes we're looking at in patients who undergo cardiac catheterization for diagnosis of constrictive pericarditis or restrictive cardiomyopathy. And this is also interesting, the quite opposite, because I already told you that the E prime velocity should be very low in patients with the myocardial disease, whether it's a cardiac amyloid or it is ischemic cardiomyopathy, hypertensive heart disease, or hypertrophic cardiomyopathy. Any myocardial disease, myocardial relaxation is reduced, especially when they're in heart failure, right? But in patients, so the E prime velocity is usually 4, 5, 6 centimeters per second. But in constriction, E prime velocity is about 9 centimeters per second or greater. So we now have a situation, even in constriction, you have the mixed disease, because now with the radiation-induced patients with the previous myocardial infarction or cardiac surgery, they have a myocardial disease and constrictive pericarditis. So when you look at this two-patient group, the blue is the pure primary constriction without myocardial disease. Their E prime velocities, almost all of them, is a greater than 9 centimeters per second. But in patients with the mixed disease, these red dots, and some of them actually do have the E prime velocity of lower than 9. It can be 6, 7, 8 centimeters per second. So it may be sometimes tough to separate this patient from myocardial disease. And because of the higher E prime velocity, E over E prime, which is the estimate of the pulmonary capillary wedge pressure, in myocardial disease, it goes up because of the E over E prime is linearly correlated to the E over E prime ratio. But here is, again, is a paradoxus, annulus paradoxus, we're calling it, but primary constriction with no myocardial involvement, E over E prime is much less than 15, but the majority of patients with the mixed constrictive pericarditis has the, not majority, almost half of them do have the E over E prime of 15, as you see here. So it's a very, very interesting concept. And that's why that when you see the high E prime velocity, meaning pure constrictive pericarditis, and the low E over E prime ratio, as you see here, low E prime velocity here, and also the normal PA systolic pressure, they have much better prognosis after constrictive pericarditis. And we just published it a couple months ago, and then this will be very helpful for us to managing our patients with the constrictive pericarditis. And here again, I return to this right atrial pressure over the pulmonary arterial wedge pressure ratio. And I know that this ratio, when it's high in patients with the restrictive cardiomyopathy, they have a worse prognosis, right? Because of the biventricular involvement with the myocardial disease. But in patients with the constriction, actually the higher ratio, median values of 0.77, 0.77 to 1.0, the higher ratio, those are the patients with the pure constrictive pericarditis with a thicker pericardium. They have a much better prognosis than the low ratio patients over here, and that's the patients with the low E over E prime ratio, as I've shown you in this slide. So if I can just summarize the last few slides of separating the primary from mixed constriction. In pure primary constrictive pericarditis, the pericardial thickness is a greater, thicker pericardium. The mixed constriction has relatively normal pericardial thickness. Not all of them, but a lot of them, a lot of patients. And the RA pressure is higher in pure constrictive pericarditis, close to wedge pressures. And then E prime is higher in primary compared to the mixed. And E over E prime is lower. And also PA systolic pressure is relatively normal in the pure constriction compared to a mixed constrictive pericarditis. So let me just then share with you a clinical spectrum of pericardial disease. There are many different ways that the constriction can present. The most common cause now for us in our practice is cardiac surgery. Okay, used to be tuberculosis, and there's still a lot of developing countries, and also a lot of idiopathic or another common cause is a previous history of a pericarditis. They present with constriction 10, 20, 30 years later, and or someone with pericardial effusion or tamponade, they can present as a constriction, as a effusive constriction, which can resolve spontaneously in some patients, but they may go to the constriction, may require a non-steroidal or steroidal medication, or sometimes even cardiac surgery. This is an example of a 54-year-old physician with a history of acute pericarditis many years ago, and now he presents with the increasing dyspnea and edema. No diagnosis for 5 years. And I saw him about 3 years ago, and an echocardiography shows you right away the septal motion change here, and IVC is plethoric. You have to think about constriction. Whenever you see a patient with HEPAF or patients with a preserved or normal ejection fraction, constrictive pericarditis has to be a differential diagnosis. And if you see any septal motion change, I think you're close to the diagnosis of constriction, okay? Because not many patients with the preserved ejection fraction, heart failure ejection, HEPAP patients has a septal motion abnormality unless they have a conduction delays and other things like that. And especially when you have the plethoric IVC, then you are even closer to the diagnosis of constriction. Then you need to demonstrate the characteristic hemodynamics of constrictive pericarditis. And he has a restrictive filling with some variation, not 25%, but the hepatic vein, which is most specific criteria of the constriction by Doppler echocardiography, has the diastolic. How do you know diastolic? Expiratory, because the fourth flow velocity is lower in expiration than inspiration. You have a significant flow reversal here. Very diagnostic for constrictive pericarditis. And also, it's interesting that the myocardium is here. Then the pericardium is tethered in constriction laterally and inferiorly posteriorly. So when you look at the strain imaging, meaning the myocardial thickness, the shortening with the contraction is markedly reduced in the area of a tethering, usually lateral or posterior segment of the heart. And that's why the E prime velocity from the lateral is actually lower, although it's very high. I mean, usually it's about 10 to 12, but it's now 16, still increased laterally, but it's lower than the medial of 20, which is quite opposite to the myocardial disease. Myocardial disease is lower, but is a higher at the lateral, lower at the medial level. So again, this is a paradoxical nature of those relationship there. And we call this as a annulus reversus because it's a reverse to the normal situation, as we see. And I think that you probably will be using it in heart failure patients. Pattern recognition, apical sparing for the cardiac amyloid, hypertrophic cardiomyopathy for the decreased strain at the basal septum, here, anterior wall, and also the posterior wall there. And then this is the patients with the apical infarct or stress cardiomyopathies, even apical hypertrophic cardiomyopathy with marked reduction in the strain at the apical segment, and the lateral and the posterior myocardial strain is reduced in patients with the constrictive pericarditis in that. So I think it's important that we also recognize effusive constriction. Some of them return to normal spontaneously, but we want to treat them with NSAID or steroid unless they have a significant chest pain, because we don't want to take any chance that they move to the chronic constrictive phase. And this is an example. We now have a lot of device, EP device, and we have the interventional structured heart disease device. These patients getting both TAVR and pacemaker implantation to manage his severe aortic valve stenosis. And patient unfortunately develop coagulant tamponade. They probably ruptured the RV free wall. and we did the pericardiocentesis and bloody fluid, and patient got better and discharged. But 2 months later, came back with more symptoms and more symptoms of heart failure and signs of heart failure and significant edema. And you can see echocardiography-wise, no fluid, but the marked increase in pericardial thickness and this dark area there because of the inflammation of the pericardium. So this is a very typical example of effusive constrictive pericarditis. Okay, and we have a Doppler echocardiography showing, similar to constriction, hepatic vein, and then a mitral inflow velocity. We treat this patient with NSAID for 2 months with a colchicine, and then a mitral inflow velocity and the hepatic vein all normalized, and patient symptoms all went away. So if we identify patients with effusive constriction early on, we can actually manage their constriction by medical therapy. We also published this data, not only the effusive constriction, but if someone has the constrictive features by echocardiography or also clinically, I think you can do most of diagnosis by echocardiography in clinical practice with a jugular venous pressure distension and then all the features I showed you. But we do cardiac MRI in most of the patients to make sure that we analyze or assess the pericardial inflammation. If someone has marked inflammation, as you see here, this is gadolinium, delayed enhancement in pericardium, and that indicates that the constriction is not yet fixed. It can be reversible with the medical therapy, and then we treat with the NSAID, with a colchicine, or sometimes steroid with a colchicine. It's really based on the levels of symptoms, and hemodynamically unstable, really New York Heart 3 or 4, we like to go straight to steroid. But if much less than that, we can try NSAID with a colchicine, and then a lot of patients can resolve their symptoms. And we also found that the patients with a reversible transient constriction by medical therapy, they have much more intense gadolinium uptake there, and also their inflammatory biomarkers like a SED rate and CRP, they are all elevated compared to the patients that who did not respond to our medical therapy. So we usually do a cardiac MRI for these patients, not just for the diagnosis of constriction, but I think looking at the reversibility of constrictive pericarditis. So again, we look at the pericardial inflammation, and also we looked at septal motion change, as you can see by echocardiography also. Okay, so this is a role of cardiac MRI. And the CT is the best for the structural delineation. Thick pericardial layer here. Although, as I mentioned before, the normal pericardial thickness does not mean that patient does not have a constriction, but the thick pericardium really helps. And we treat this patient with a steroid in 1 week. Everything is normalized. Pericardium is normal and no pleural effusion. And we usually continue our treatment for about 3 months with a good tapering strategy with a colchicine, and then a patient can recover from hemodynamically significant constrictive pericarditis. So this effusive constriction definition is you have an increased right atrial pressure and the intrapericardial pressure at baseline. After pericardiocentesis, still RA pressure is elevated, as you see here. And then in this particular report, the 9 of 13 patients required pericardiectomy. And we have this data 20 years later showing that only 7 out of 15, that's 50% of patients, and 8% of them after pericardiocentesis had the effusive constrictive pericarditis. And they used the right heart cardiac catheterization to diagnose that. But we now used echocardiography. This is our data, the 205 consecutive patients. And then we found that 16% of them has effusive constrictive pericarditis there. So it's more frequent in patients with a hemopericardium, especially with during the device therapy, as I shown you before. And In our practice, though, we treat most of the patients after pericardiocentesis with the NSAID or steroid, NSAID and colchicine anyway. It's only 2 patients required pericardiectomy in 3.8-year follow-up, as you see here. This is another example of effusive constriction, presents with tamponade and underwent pericardial window, but patients still having trouble. And then here is the jugular venous pressure elevation. And then this is a Doppler echocardiography showing marked septal motion abnormality. We always do the M mode, which is most reliable looking at the septal motion abnormality, hepatic vein, mitral inflow velocity, elevated E prime velocity. We treat this patient with the steroid and the colchicine did not respond, so we had to go ahead with the pericardiectomy. And this is intraop, the video of pericardiectomy. You can see the thickened pericardium, and then the heart bulges through the open pericardial layer there because of the constriction there. And you can see our volume of constriction once we have the more understanding from Dr. Liv Hadley's visit in 1980s, late 1980s, and echocardiography and also hemodynamic cardiac catheterization all together, and CT and cardiac MRI. We diagnose more patients, and we are now doing 75 to 100 pericardiectomies a year at the Mayo Clinic to deal with these patients. And the radiation and post-op has much worse prognosis compared to idiopathic viral pericarditis. And also important to note that the tricuspid regurgitation is important because the 53% of them with the constriction has no TR. But once you have a even mild tricuspid regurgitation, you have a much worse prognosis. I think one of the reasons is also that this is a patient with a constriction. You can see the indented because of the pericardial mass there. Once you remove that, your annulus is enlarged, and you end up developing more severe tricuspid valve regurgitation. So we have to make sure when you do intraoperative transesophageal echocardiography in patients undergoing pericardiectomy. And this is a patient actually also having some indentation in the left side chamber. And then this is a baseline of the mild mitral regurg, but after pericardiectomy became severe that they have to do mitral valve repair. So we have to really pay attention to the AV valve regurgitation after pericardiectomy. So if I can just summarize, I think that pericardial disease has a lot of spectrum: inflammation with pericarditis, fluid with effusion and tamponade, and then scar with constrictive pericarditis. And I think the multimodality imaging is quite valuable. And also the constriction diagnosis really has to be based on hemodynamics. Whether you do echocardiography or cardiac catheterization, you don't really have to do both. If you feel comfortable with one diagnostic hemodynamics for constriction. And also you have to understand the effusive constriction. It happens up to 20%, and the medical therapy is possible. But if nothing works, then no medical therapy is helpful, then you have to go through the pericardiectomy as a choice. But also in your practice and also board exam, they probably going to ask you about the mimicry, because constriction can mimic some other disease. And this is a patient who were undergoing liver transplant. They did a whole evaluation of transplant because of the liver function abnormality, hepatomegaly and things. But during general medical examination, you can see the Kussmaul sign and all the echo MRI, all of that showing the constriction. So constriction can be a diagnosis was a liver disease. It happens very not infrequently. And this is a patient I was seeing in valve clinic, came for the severe aortic valve stenosis, the low flow, low gradient, only a 26 millimeter mercury with a severe AS. But the much inflow is restrictive, and the increase E prime velocity, even with severe AS, that's kind of unusual. So when you look at the hepatic vein, there is a typical diastolic flow reversible constriction. So this is a patient with the radiation heart disease, which caused the valve disease and also the constrictive pericarditis. So we got to make sure that we discover this disease, which can be sometimes quite challenging in our clinical practice. So things to remember for your board and practice. This is a really curable diastolic heart failure, as I shown you. And phenotypically, but the many features are quite similar to restriction, myocardial disease, but quite distinct hemodynamics, as I shown you, right? The interventricular dependence in Cath and echocardiography. And also the diagnosis should be based on these features, as I shown you. And this one, again, very paradoxical to the myocardial disease, annulus paradoxus, annulus reversus, pressure change, LV and RV, discordance and concordance, and hepatic vein diastolic flow reversal, expiration, not inspiration, as in myocardial disease. And also you have to understand the treatment based on the what you see in the cardiac MRI and duration of disease, and then clinical setting of that particular patients. And also you have to pay attention to the tricuspid and mitral valve regurgitation intraoperatively. And finally, everybody knows Dr. Paul Dudley White, who really was a pioneer in constriction in 1920s and 1930s in Mass General. And then at that time, he showed this picture of a patient, ascites improved after pericardectomy in 1930s. And then he said that establishing the diagnosis of constriction is very, very important in threefold. And actually, I was giving grand rounds at the Mass General a couple of years ago, and I used this slide because we still have the same problems. Because it affords the explanation of a group of patients with the symptoms and signs of constriction, which can be from some other disease too. And also, obvious confusion with other conditions. We have seen patients coming to us with a cardiac amyloid turned out to be constriction, vice versa. And also, the most importantly, experienced cardiac surgeons can now cure this problem that once thought to be a hopeless disease. So I think it's very, very important that we diagnose constriction. For us to do that, we have to remember constriction as one of the conditions that cause right heart failure and heart failure with a preserved ejection fraction.